All right, we'll get started. My name is Pat Lennon. I work with PATH, and I welcome you to the last day of TechNet. I'm conflicted. I'm sad to have this be our last time together, last day together. But at the same time, my brain is really full of great ideas and conversations and meeting new people. So I think my brain will need a break after this. Um, so welcome to the Increasing Stock Visibility for Improved Decision-Making and Access to Health and Healthcare. We have two presenters today. One will be a pre-recorded video. They weren't able to make it. And luckily, we have a presenter in 3D. In this session, we're going to delve into questions such as, is digital literacy of the users or access to the internet the pivotal factor for data system utilization? What contributes to cost efficiency when implementing digital data systems? And what improvements can we achieve in reducing stockout rates? So in order to get those insights, we will be starting with Stefano Malvolti, representing MMGH Consulting. And following that will be our recorded presentation from Mohammed-Faosy Adeniran from eHealth Africa. One of the great benefits of TechNet is getting to know new people. I like seeing the old friends and making connections. But with Stefano, he's a great example for me of someone I didn't know before the conference, but preparing for this session, getting to understand his breadth of expertise, his depth of knowledge, his ability to communicate information clearly, working across many countries in many areas. Very impressive capability and experience and background that I hope you will benefit from when he does his presentation. So Stefano, I think the stage is yours.
Thank you. Yes, again. Okay, so yeah, I can see the slides, I can see the time that I got available. So, good morning, bon dia, everyone. It's really a pleasure to be here today to present on behalf also of Bocconi University in Milan, this multi-country programmatic and financial evaluation of ELMIS and EIR. We will, of course, pay attention on stock visibility, but there are many cross-system learnings coming from EIR that we thought would be very relevant for the discussion today. And before introducing the 4 countries where the study was performed are Guinea, Honduras, Rwanda, and Tanzania. So we have also one example of a country very close to Panama. Yes. Oh. Okay, I found it. So the study was performed, as mentioned, by Bocconi University and MMGH Consulting with support from 4 in-country partners that helped us with the primary data research. And as I said, I mean, the ultimate goal of the study was really to generate understanding on the impact of EIR and ELMIS in supporting countries taking decisions about their expansion, their modification, their adoption across the various systems and processes. The study was guided by 4 main research questions: whether the use of EIR and ELMIS has improved immunization service delivery and outcomes, whether in the short and medium term there will be financial and economic gain from the implementation of those systems, and how affordable and sustainable are they. We look at interoperability, and we'll touch base on that extensively, and ultimately whether future investment from donors and countries can be informed by this type of study that provides some additional evidence. Quickly on the methodology, it was used a mixed method approach, so a mix of primary and secondary data research. There was extensive data research in the country, used purposive sampling. Between 25 and 80 health facilities were investigated, so the results come really, I mean, from the field. And originally, the attempted to define modeling to evaluate outcome results. This was not possible. It proved extremely difficult to do something serious. I mean, of course, you can always build disease transmission model and estimate outcomes, but the establishment of the causal relationship between the different variables up, down to outcome we felt would have not been methodologically sustainable. So we ended up, focusing, you'll see, on output and process indicator. Nonetheless, those allow us to, we think, identify substantial and interesting findings. And I'll start from there. So we have basically 13 main findings that that emerged from the study and we want to share with you today. And then we will deep dive a little bit more on the ecosystem, on the implementation, and on the financing of those systems. The first one, donors and partner expectations are often not aligned with national objectives. We see that not that any of that was wrong, but there were some expectations that were in the original funding of grants to the implementation of the systems. And then we speak with the Minister of Health, he realized that the goal in country were different. We'll get more into that because it's definitely an interesting finding. There was over-reliance on external support from consultants from the north coming into the south. This generated dependencies and sometimes even distorted priorities and implementation plans. Constraints in the infrastructural level, both IT, electricity, basic, availability of computers were, very common across the board. There were technical limitations in the design choices. We'll come back into that because we felt it was very important. Health worker and the health facilities were not at the center of the design of those tools, and this has a number of implications. On the other hand, user satisfaction was generally high. People enjoyed and were positive about the use of those tools, despite seeing the limitation. Many of them saw the potential of those tools. Supportive supervision was important because one of the key elements was really raising attention on data quality, and that feedback loop provided, some positive results irrespective of the limitations. Generally, phased rollout strategies were adopted and policies were put in place to allow the implementation of electronic system. There was perceived data quality improvement, and we registered data quality improvement. This primarily because of the supportive supervision and the transparency that those systems make possible in the field. The point of today, data for decision making, we didn't see much of an improvement in that field, unfortunately. Number one, because this was not one of the main goals of the implementation of the system. At least in those 4 countries, the main goal was transparency and the related accountability, not so much about activating the feedback loop. And very often the feedback loop that can help decision making was not possible for technical reasons, and other technical factors impeded health workers in the point of delivery of vaccination, or the next level, if we're talking about inventory management, to have online access to the information, hence preventing physically them to benefit from those tool implementation. On the other hand, looking at the output, in one country, the ER positively impacted service delivery processes, both in terms of perceived quality from the users, from the caregiver, as well as from the health worker in the field. And talking about the LMIS, in the case of Guinea, there were statistically significant improvement in vaccine stock level. So we didn't even do statistical analysis, and it was there. You can argue the sample is small, could be driven by many factors, but at least, the direction was definitely positive. Mixed evidence and cost savings, we'll come back to that because it's very important, and therefore on affordability and sustainability. You've seen, it's not rocket science. Probably most of you have a clear understanding that these are the problems, but we felt it was important to kind of justify them and ground them on facts, on study across multiple countries. And this can help building a mental checklist of what needs to be done, this system to be successful, and what can be achieved if possible. Now, we want really to share a couple of specific examples, really real life example from those 4 countries. The first point, I see many of you smiling about the misalignment between expectations of donors or technical partners and countries and Minister of Health. Technical partners and donors expect improvement in outcomes, increasing coverage and reduction in mortality and morbidity, or improvement in stock level and reduction in expenditure, hence reduction in health outcome. Countries were all focused much more on processes, improvement in the process, on the output, the measurement of can we reach more kids, can we list more kids even more than reach, can we put in our database more kids, can we have control on our inventories, even more, having control even more than what the level of inventory is. The focus was definitely on transparency, on reporting back to the center, and on monitoring program performance. Does the supply chain system works? Does the immunization ability of reaching out kids is improved? Not so much the following step. And this led to, of course, some mis-expectation. Again, one clear example in Honduras, we heard very clearly the goal of implementation of the system is having good reporting about the performance of the immunization activities, of are we reaching the kids that are in the system. It was not about zero dose children. There is no integration with the civil registry, so there was no goal, no ambition of doing so. This is very different from what you hear from the funding coming from above. Not that the country doesn't want, but the obstacle to get to that point were too high. On the conversely, on the external support, I mean, not surprisingly, there is, I mean, a lot of dependence on external support. Example of Tanzania is the most striking. Two systems, EIS and ELMIS and EIR rolled out in parallel, integrated, systems start working, phase rollout, stop of the contact with external contractors and partners, system start experiencing IT issues, design issues, and progressively reduction of the use of the system in the country. That's the only reason, the discontinuation of the support from the consultant? Probably not, but indeed is a component of that. Another point of this alignment, I mean, also we need to be very careful, and one big learning, align with the Minister of Health kind of goals and support them. We have one country, I'm not going to mention, not to put anybody under the spot, but one country in which the country had a specific strategy and technical partners were pushing the country in a different direction, to use a different tool from the one they were trying to implement to use. And this does not help, I mean, ownership at country level. Still sticking at the ecosystem level, technical constraints. I mean, you're all familiar with technical constraints of electronic system. Some are very trivial. You can see, oh, that is really, I mean, what are we talking about? Those trivial constraints are the biggest obstacle. I'm sure if you leave that on your directly, are some of the biggest obstacle in utilization and the impact of the system. Couple of examples: lack of money for renewing licenses. You don't have the latest license of Windows, the last instance of the software will not work in that computer. The computers are not located in the immunization. This is less ELMIS, is more EIR related, is not located physically in the room where immunization gets administered. Your EIR doesn't serve and doesn't help the health worker. Too bad that in an health facility, in a remote health facility, they don't have one computer per program, per service in every room. But if you don't consider that, all your design is going to collapse. Internet access, if it is low, all cloud-based services are impacted. If your servers don't have enough capacity to host a very nicely designed and super, very performing tool, the tool will not work for the health worker and will be progressively discontinued. One last topic, security of health worker. If you have to use your tool on the go in an outreach activities, again, it's something that has to do more with the EIR, but also ELMIS. If you follow, I mean, the consumption of doses in outreach, you need to take with you a portable device. If taking the portable device has security implication for the health worker, they will not take it with them, and the entire implementation will be affected. So technical limitations are many and far-reaching and can impact greatly, even if they are tiny little things, the ability of the system to operate. The design is also another important dimension. We realize that the design is rarely, at least in the 4 countries, a small sample, we cannot extend to everybody, but in those 4 countries, the attention for what are the needs of the service delivery level, whether it's an EIR or an ELMIS, and the needs of the health worker were very minimal. One striking example, again, is an EIR example, but applies very well also to ELMIS. In one of the countries, the implementation of the EIR required, because the computer was not in the room, the health worker to fill a second paper form. It was exactly the same paper form. One structured by date, that was the by kids, name of the kids, that was the pre-existing legacy paperwork, now was structured by date. The information is exactly the same. The two forms had to be filled, the second to allow at the end of the day or the end of the week a data entry person to do the data entry into the system. That meant double amount of time for the health workers. Can you imagine the motivation of putting good data into that system? And has implication, of course, also on the financial standpoint, because it's more time of the health workers spent in data entry activities. Coming to cost, the last point of our evaluation. So the upfront investment is very useful, it's catalytic. Support of donors, support of partner entities is very useful because it's often a very heavy lift to establish the system. It should be done with care without, again, pushing in the wrong direction for the implementation and for the design, taking into account what are the goals of the country. However, we should be taking into account that the design should be done with sustainability in mind. So duplication of activities, so extra expenditure that are not sustainable in the long run or not budgeted, like the cost for licenses, need to all be accounted for to measure whether the system is going to be accountable and to allow for a budget line to be beefed up to account for those elements. All those things generally are kind of not fully taken care in the moment the decision of implementing an ELMIS or an EIR is taken. And more importantly of all, linked to the application of activities, we did perform a complete analysis of what is the current cost, what was the legacy cost with the paper-only system, what is the current cost. All situations were hybrid, so they were paper and electronic running in parallel. And as you can see, the cost is not going to go down in a hybrid situation for a number of reasons. The only big benefit you achieve if you move fully digital. And of the 4 countries, Rwanda is the one that is progressing very well in that direction, and they will be able to see effective data saving on the economic standpoint, therefore improving sustainability. I'm seeing that 39 seconds left, so that is my last slide. So 5 take-home messages that we, in our opinion, emerged from our study. The 2 electronic tools to support decision-making should do that at the delivery point. Hence, need to be designed with that element in mind, need to meet programmatic need, and need to have in mind that the end state is a fully digital setup. That's the only way in which decision-making can be positively impacted, including for ELMIS. To allow sustainable sustained use, and this is especially true for ELMIS, there should be an integrated approach across all as many primary healthcare programs as possible. At the end of the day, as much as vaccination has some specific requirements, the backbone of ELMIS is the same across all health programs. A functioning IT ecosystem and local capacity as preconditions and need to be met before thinking about any investment of the kind. Otherwise, the money will be spent for nothing or getting much less return. And 2 kind of side call for action. 1 for more implementation research. Our study was 4 countries, field primary research, but not a large sample. We cannot pretend those findings to be generalized and universal, and there is a need of understanding really what is the impact on outcome, and again, it was difficult to achieve that in scope. And the last point, monitoring and evaluation at country level should be planned since the very beginning. We saw very positive feedback loop activated, even with limited monitoring and evaluation. That's the best way for country on ELMIS and EIR to start the process of progressive and continuous learning and improvement. But again, if this is not designed at the very beginning, it's not going to happen. With that, with probably 30-second excess time, I finish my presentation.
Well done. Thank you for that information-rich presentation. So now we're going to move to the video. He hopes. Faosy recorded this for us, and if you're online, thank you for doing that. If you guys are ready.
Happy to be here today. Unfortunately, not physically. I wish we could have it otherwise. I'm here today to talk to you about the logistics management information system called LOMI-SUIT in improving supply chain management in low-resource settings. I'm Mohammed-Faosy Adeniran, and I'm a project manager with eHealth Africa. I believe Stefano was able to give us enough background, and these problems he has mentioned are universal. Those are the same problems we encounter. However, to be able to provide proper visibility and accountability, also making the product available, eHealth developed a tool called Lomis. Lomis Suite has two components. You have the Lomis Deliver and the Lomis Stock. Eventually, we'll get into that, but yes, this is the content we'll be covering for today, and I'll move to the next slide. So, just to talk about Lomis, when we started delivery of vaccines, we needed something to be able to provide that logistics management information for us, so that it would be quick for us to get reports out, as well as eliminate paper trails. And eHealth developed Lomis to address supply chain challenges, especially around hard-to-reach areas. Most of the problem of Lomis, or Lomis was built to address most of this problem highlighted earlier by Stefano. And one of them, like we all know, is a low visibility of stock availability at the last mile health facility. So when the government wants to make decisions, when you want to make informed decisions, you need to be sure that you're able to get enough data to make those decisions. That wasn't available back then. Then most of the reports are manually generated, and it takes a very long time before these reports are able to come out. There's also a problem of accountability. It's always hard to get accountability on what was usage, as well as know what the wastages are. Then there are errors in data collection, right? Which is generally going to happen when the process is very manual. And to be able to address the degree of stockouts, or minimize the stockout rate at the last mile health facility or cold chain equipped health facility, we had to find a solution to be able to bring those things out, and Lomis was developed. I'll put it simple. How does Lomis work? As I explained earlier, we have the Lomis Stock and the Lomis Deliver. It's one suite. The Lomis Stock has to do with reporting stock utilization at the last mile health facility. That's for the vaccine. You'll be reporting your usage, what you've used, and it's able to tell you when you're running low on the vaccine, so that you can quickly make a request. Lomis Deliver, on the other hand, this is being used by the health delivery officer. So eHealth, for example, have some states where they have partnership with the government, and they are able to deliver vaccines from the state central cold store to these cold chain equipped health facilities. So when these vaccines are being moved, we need to understand how they are being moved, what quantity is being moved, who is receiving them at the destination, what's the temperature excursion when they were being moved. So I'm going to talk about the use case for this, especially around supply chain. I know we're limited on time, so I'll just breeze through it. Around supply chain, the current project Lomis is being used on is called the VDD, Vaccine Direct Delivery Project. And this Vaccine Direct Delivery Project delivers vaccines to cold chain equipped health facilities. We have a lot of health facilities, primary, secondary, tertiary, but not all of them are equipped to store vaccines, right? So these particular targeted health facilities are those we deliver to. Currently, we deliver to over 300 health facilities monthly, and this is done over a period of 2 weeks. We pick up the vaccines from the state central cold store and deliver across the LGAs, and this is at world level LGAs. Then we have where we pre-position buffer stocks. LOMIS has been used, or we've piloted the VDD project in about 4 states, right? 3 of the states have been transitioned to the government. So we have the Bauchi, Zamfara, and Kano were transitioned to the government, while Sokoto is still currently going on. And I'm going to take you through the process pre-launch, before we start the delivery process, the regular process of having your confirmation of the list, and the state logistics officer notifies eHealth that, hey, you need to carry out deliveries to these health facilities as based on the previous schedule you've done. So if we deliver, say, on the 1st of September, right, for the previous month, so that we make sure we meet that same timeline, we would likely deliver to that same health facility on the 1st of October to ensure that we're able to monitor their consumption level. Well, the deliveries are scheduled. The health delivery officers, we call them HDOs, go to the health facilities to pick up these vaccines. When they pick up the vaccines, they ensure that their VVM status are intact. They put them in the PQS boxes lined with ice packs. We put in temperature monitoring devices. They are log tags, and these log tags have the capability to send information wirelessly to the driver's phone. Then we deliver to the LGA cold stores. The LGA cold stores is just to hold buffer stock, as stated earlier. In some cases, we have some failed deliveries, and we have some cancelled deliveries. Failed deliveries come when we get to the health facility. The health facility in charge isn't available for some reasons. Yeah, there are different reasons. Like, we could have security issues, and they had to quickly evacuate from the health facility. Then we have cancel that mostly maybe when the coaching equipment is faulty, right? Like I mentioned earlier, we do the monitoring in transit. Then what we've been able to integrate is we have another tool where we call it Pogo LTE and Varo. So one helps curate data on the dashboard and present it on the performance of the coaching equipment. Then the other one is to help the health delivery officer collect the performance from the fridge tags. We're able to monitor this, and we're able to quickly notify the states when health facilities coaching equipment are becoming faulty or they're having a problem. We're able to notify them. So this is the general process of delivery that we go on with LOMIS around the VDD project. What are the benefits and potential impacts this has made since implementing LOMIS along with the VDD project? I'll tell you, since we started, we've delivered over 21 million antigens in Sokoto currently. 21 million antigens have been delivered. We've delivered over 23 million dry goods. And these dry goods include syringes, other cards, vaccination cards, and the rest. We've had over 17,000 successful deliveries. Another thing we've had is the rate of reduction in the stockout rate, right? When we started inception in 2016, December 2016, the stockout rate in these health facilities were very high. They were in the range of 61%. So you can imagine if a mother or a nursing mother and a child needs to be vaccinated and they get to a health facility and vaccines are not available, right? And in the past, just take you back a bit, in the past, it used to be a pool model, right? It used to be a pool model whereby the health facility in charge has to leave his health facility to go to the state central cold store to pick up vaccines. So when parents or mothers visit the health facility with their infants, they don't meet the health facility in charge to even do the vaccination for them. So those complexities were corrected, and that's where organizations like eHealth came in and partnered with the state, and were able to take that hassle off them. Rather than have people come all the way to pool vaccine, we are the one pushing. So we've been able to push the stockout rate from the high rate of 61% to 8% to a single digit. Yeah, there are times where we would have slightly higher. That's when there are stockouts from the state central also. So say, for example, we go to pick up some vaccines and it turns out during that period, the rotavirus vaccine is out of stock there, or they have very minimal vaccines available. So what we tend to do is we take the few available and see how we can allocate. So Loomis does all those reallocation for us, and we're able to say, hey, we took this number. So it reallocates it in a way that at least they get a minimum. So our stockout rate reduced from 61% to 8%. And this is one of the highlights, the major thing that shows that, yes, we have that. Since we started, from the records, so when we go to deliver, we're mandated to take back the usage data, right, from the health facilities. They are supposed to submit KPIs. The KPI forms report how many children were vaccinated, how many vaccines were used, number of vaccines that were used, and all of that. So we've been able to record 8.4 million children, over 8.4 million children have been reported immunized. It should be higher than this, ideally, because there are instances where we don't have KPIs being submitted by the health facility in charge, where we escalate the state logistics officer and they are able to address it from their side. In conclusion, more needs to be done, right? I'll be honest, more needs to be done. Loomis has contributed immensely. It has provided last mile visibility. It has increased access to healthcare services for communities that's hard to reach communities. And ultimately, we've achieved the goal of getting closer to the target of universal health coverage for underserved community. But we still have the issue of sustainability. When we transition this project eventually to the government, will the government be able to sustain it? I'm going to leave us with that thought. So let it be our takeaway from here so we can discuss. And I will pause for now for your questions. Thank you for listening to me. Should you have time or you would want to find out more about what we do at eHealth Africa, you can scan the QR codes or click on the links embedded with each QR code to get more information. Thank you very much. And like I said, I wish I was there with you guys. Thank you. I'll be on standby for your questions.
Faosy, thank you so much for recording that video. One artifact of having his handsome...
Reach out to me on the information provided. If you have, if you require more information or you want me to answer specific questions. Thank you. Bye.
Are you done, Faosy? All right, now he's done. Okay. One artifact of having his handsome face on the screen was that he covered up some key data. So the reduction in stockout rates from 61 to 8%, I just wanted to highlight that. So he did kind of cover that data point up. All right, I think we can open for questions. And unsurprisingly, Dorothy's ready to go. Can we get a microphone for Dorothy, please?
He's my friend now. Good morning, and thank you very much for the presentation. So I have some questions for Mohammed-Faosy regarding the low MIS. The key question was about in Nigeria, did they define the specific strategy to scale up the ELMIS? And my second question would be a little link, because you know in Nigeria maybe they have several ELMS. So what is the strategy for integration, whatever the commodities? So that was my two questions to Mohammed-Faosy. Then for Mr. Stefano, very interesting evaluation, very inspiring. Thank you so much for the information. But it came to me to think about you talk about the ecosystem, which is quite important, but did you investigate if in this country there was already an ELMI strategy, e-health strategy? Because most of the time we say it costs a lot of money, then you need to procure devices, whatever, and things like this. But in general, if there is already IT governance or e-health governance in the country, you can save money, right? You can use the existing investment of the country in this area. Then a second aspect that came to me, you mentioned about the critical issue of ownership, country leadership. It's like innovation coming from external partners, right, into the country. So I was just wondering to which extent in these countries, Guinea, Honduras, Rwanda, and Tanzania, if there is any innovation strategy. Because currently we talk about EIR, or ELMS, but actually we talk about any innovation, right? So what is difficult to, I mean, for this country and whatever the country is the vision of the country to change the way of working, to invest, in a long-term perspective. And then this is to ask the question about the sustainability, because I understand that ELMS is quite expensive. We have been supporting Gavi Secretariat developing the ELMS scale-up strategy, and we understand very well that it's quite costly. And what is currently based on your evaluation, your recommendation for the sustainability of this one? And maybe the final question, when you look at EIR and ELMS, did you investigate also the interest of integration or interoperability of the two systems? Because when you have the immunization registries, then there will be impact automatically on the needs, the forecasting, and so on. So I don't know if you investigated this point. Thank you very much.
Dorothy, thank you for those really good questions. The questions for Faosy, he's not here, so I don't have the expertise to answer those with confidence. Stefano, I don't know if you have any insights on that. So we'll make sure he gets those questions. But Stefano, if you want to go.
No, thanks for the question. The first one on the ecosystem, yes, very positively, 3 of the 4 countries, so Guinea, Rwanda, and Tanzania, had digitalization strategies in place, developed relatively recently, and they were acting according to those to a great extent, I would say. So this was not, WISE was externally funded and in some cases heavily extendedly supported. They were not kind of in a vacuum. They were implemented as part of the broader design. So this was very positive. And also Honduras, it was the one that didn't have a specific extended digitalization strategy, had a strategy overall, also with the help of PAO, the PAO regional office, for digitalization of their services. So a little bit less developed than the other 3 countries, but also there was not just implemented into a void. And we saw that the benefit, of course, of, in particular, to me the most striking example was Guinea, of having that cross-program digitalization strategy for the Minister of Health, and this being cascading down in a number of interventions. So the importance of that strategy is critical, also to provide a guidance. Again, since we are in the PAO region, I will also mention that having a regional strategy do help countries a lot, putting a framework around their intervention. So the fact that Honduras is a little less developed country strategy was kind of partially compensated by the existence of a strong strategy at regional level. So there are probably different modality of doing so. In terms of the country ownership and innovation strategies, we didn't register any specifically design strategy for innovation as such. And we didn't perceive that as a problem. You don't innovate just for the sake of innovation, especially not at country level. What I can say that, probably the most advanced or different, again, example is the one of Guinea. For their cross-program approach, the ELMIS in Guinea is supposed to work across 14 different health programs. And this was driven as a response to the Ebola crisis in the 2014-13 when it was. in which they realized that having control on the flow of goods across multiple programs was essential for their response. And that triggered what can we do better to have an integrated approach, start developing this integrated system across multiple programs, running at the beginning for Ebola, then expanding to malaria, then to other programs, including immunization, and then with the goal of covering basically all the 14 key health programs. And the program is progressing. And when we were there, they already had covered 9 programs out of all of them. And this, I quote the example of Guinea because to me has a strong linkage with the economic sustainability. I mean, the fact that you can achieve economies of scope and economies of scale of having one single system across health programs is paramount to achieve sustainability of the system. You need to share the costs across multiple programs and is feasible, in particular for ELMIS. EIR is a slightly different story. You have different target population. You can do that as well, but it's more complex. Again, ELMIS, despite what we heard in some cases, yes, there are elements that are specific to the immunization and to the vaccine refrigeration, even if it's not only vaccines that are refrigerated, but definitely, and there are specific elements, but it should not prevent an integrated approach to logistic management system. The last point about interoperability, the example of Tanzania is very good. Tanzania had 2 different systems, VIMS and TIMER, the name of the 2 systems, and they were progressively designed to operate together. I mean, to be more than interoperable, they were really integrated so that the information flowing from the electronic immunization registry can be a solid feed into all the planning activities for logistic management system. So the example of Tanzania, even if with element of black and white, because it's the country that has reduced utilization of the system as a result of some issues in extra dependency on external support. But if we look at where it worked, in the facility where it worked, the integration delivered good return, good advantages, was a positive experience, and should be looked at more carefully because can provide a good number of learnings in terms about interoperability and integration.
Thank you. We have time for one more question. Karan, can we get microphone is coming your way.
Thank you to both the speakers. Stefano, one question I had, and you mentioned it, it's coming out very clearly, is the sustainability angle. So beyond the integration aspect, which you just mentioned, what are the other key things that you, from your interactions with the countries, found out that would help them to really sustain these programs on their own after the donor monies run out or are phased out? And I'm particularly interested to know if you had some kind of analyses wherein you were able to say that these systems, once implemented at scale, would start paying you off in a period of time, say by example reducing the inventories in the stock holdings or the inventories in the system, where countries don't, being more efficient, they don't need to buy more, and with buying more you could maybe reduce the wastage and other things, so reducing that wastage element. So what was that also maybe something that you had looked at?
Yeah, so in terms of sustainability, I will look from 2 standpoints. In terms of sustained use, because ultimately you want this system to be used, hence the need of be very careful about design. Again, the system is usable and is going to be delivering benefit if the data quality is there. Data quality is dependent ultimately on the health worker using the system, seeing value of the system, seeing value of having data quality into the system. So again, going back to the message, need to be designed with the end user in mind, to me is paramount. So any design that starts from the top and eventually trickle down to the bottom is not going to be sustainable from a usability standpoint. We have heard repeatedly health worker lamenting, this doesn't help me, I'm going to do it because I need to do it, but again, no surprise, and the quality is impacted. So from a usability standpoint, check that the design is done to, first of all, favor the last mile, to favor whatever is the stock keeping unit or what is the health worker last immunization delivery point. On the financial standpoint, the key paramount, what emerged very clearly, there should be, again, in the design, an end state that is reachable and it is only digital. If it's not only digital, it's going to cost more money on top of creating extra burden on health worker. So any design, and I would say any financing should go only if that program has as an end state full digitalization. And if it's not achievable and it's targeting a hybrid solution, a lot of care should be looked at what hybrid mean. Hybrid should not mean duplication. Duplication is a paramount element of lack of sustainability. In terms of the paying off, well, I mean, if you get to the fully digital, one payoff will be to the lowering of your costs. Every year, compared to the legacy situation, we spend X% less, so that cumulative saving will eventually pay off your initial investment. In terms of the next step of reduction of working capital, because you're carrying on less inventories, or because you can reduce stockouts or emergency shipment, we only did an estimate of the cost of emergency shipments. So we factored in that, we can discuss more in detail and you can look at the report. We factored in for the LMIS the cost of an emergency shipment because we have too low level of inventories, and this is factored in. So when you compare the reduced cost of the functioning fully digital system, it does capture already also the benefit of avoiding have emergency shipment. A full-blown calculation, including, okay, I'm carrying on 30% less inventories, there is less money spent, I need to reorder less and so forth. This has not been done. We didn't have sufficient data to be able to do so.
All right, thank you. Unfortunately, we've reached the end of our time together, and join me in offering one more round of applause for the speakers.